So, wir machen weiter. Der Christopher wird unseren nächsten Referenten vorstellen.
Okay, we'll continue, and Christopher is going to introduce our next speaker.
Okay, also next.
Okay, the next speaker is Dr. Jeremy Kirk, and he's going to talk about hormones. Thank you.
Dankeschön. Willkommen. Guten Tag. You'll be pleased to know that's the limit of my German. Other than there's one more phrase that I'm very fond of, and it's zwei Bier bitte. But I won't be asking for that during the course of this talk. I'm going to talk about puberty and hormones, and I've seen some of you already in some of the consultations. You'll be pleased to know I am not planning to talk for 2 hours, so hopefully you'll have plenty of time before the buffet this evening. Thank you very much for inviting me to this meeting. I have to say I've been to a number of meetings and I've been to a number of CHARGE meetings. I think this meeting is unique. I have never, unique in a good way. It can be unique in a bad. I've never come across a meeting as organized like this. I think it's absolutely fantastic. I think you have an amazing family group, and we're very jealous of the family group that you have in Germany and the UK. So if we steal any of your ideas, imitation is the sincerest form of flattery. I'd like to thank Claudia and Julia and all the people who've organized the meeting, for you for coming. I'd also like to say thank you, because I'm not going to be easy to follow, to the signers and the interpreters. I think have also done a fantastic job. So thank you very much indeed for that. So I'm going to talk. So all you ever wanted to know about sex hormones, preparing for puberty or sexuality, but I think it should be called sex, drugs, and rock and roll. So I'll tell you a little bit about myself. So my name is Jeremy Kirk, and I come from the UK. I'm actually my family originally from the East Midlands, but I was brought up in London, and I moved to the West Midlands. And the Midlands, as they say, are the Middlelands. They're not in the north, they're not in the south. And London is the largest city in the UK. Has anyone heard of Birmingham? Thank you. When I go to the American meeting, they have heard of Birmingham, but it's the Birmingham in Alabama. This is the original Birmingham, it's in the UK. So Birmingham has a population of 1 million. The conurbation is about 3.5 million. And so this is all industrial city, very much like the Ruhr, historically. And around here we have about 100 kilometers in each direction. We have the shires. Now the shires are the areas of farmland. Hold that thought with the shires, because I'll be asking some questions in a minute. We've got some famous people. Everyone knows who this is, do they? Thank you. William Shakespeare. Charles Darwin. So charge is a genetic situation. Charles Darwin really started off looking at genetics. And because we're in Germany, if you're not looking at the next one, anyone who hasn't looked at the slides and hasn't heard the talk before, does anyone know who this is? It's Tolkien. And the reason I've used Tolkien is Tolkien's family, although Tolkien was born in Birmingham, Tolkien's family came from Saxony in northern Germany. Okay? And much of The Lord of the Rings is based on areas around Birmingham. So this is where he was born. This is the mill. From my office, these are the 2 towers. And because Birmingham was very industrial, to the north of Birmingham, which is called the Black Country, because it was very, very black, it's thought to be Mordor. Terrible place to go. It is so terrible that when Queen Victoria would catch the train from London to Scotland, she instructed that the curtains of the royal train were closed as she went through the Black Country. So what other links do we have in the Middle Lands with Germany? So, of course, when the Romans left the UK, we had the Germans come across, the Angles and the Saxons. And my name is Kirk. It's an Anglo-Saxon name. You brought us a lot of culture, and people moved here. And you brought us some of your language. So the name for most of the animals is Anglo-Saxon from Germany. The name of most of our food is Anglo-Saxon. But most importantly, every single swear word in English, almost without exception, comes from Anglo-Saxon, from Germany. So thank you very much indeed. I'm not going to use any words like Nancy did. We did have a discussion about me using them, but they're all from Germany. So you've brought us some fantastic culture. And so people came from Germany. Is anyone here from Norway, Sweden, or Denmark? Yeah. So the Germans came, and then sadly, the Vikings came afterwards, and they pushed everyone down. So the Middle Lands were squeezed, and so this is the first kingdom, but we had to pay the Vikings money. This area was called Danegeld. We gave the money to the Vikings to stop them coming into the rest of England. And this man produced the, so Mercia, which is the Middle Lands, was the first major kingdom of England. And actually, if you look at Offa, who was the first king of England, is that a charge ear? Or is that a charge ear? And I looked at these. I thought, are these sloping shoulders? Are these wings scapulae? Does anyone know what they are? Now, if you want to know, so this is England, this is Wales. The English people didn't like the Welsh people. If you want to know a Welsh person, you can go and meet David Brown, who's sitting there. He built a big ditch at Offa's Dyke to keep the Welsh out of England. David would argue it was to keep the English out of Wales. Now, unfortunately, if things don't go well next week, we'll be building a big ditch all the way around the United Kingdom. But that's not going to happen because we're not going to vote for Brexit because we want to be part of Europe. So thank you very much indeed for that. Sorry. So I'm going to talk about hormones and puberty, but many of the hormones that are involved in puberty are also involved early on. So there are often some pointers for that. So I'm going to talk about hormones, I'm going to talk about puberty, I'm going to talk about hormone replacement therapy because I know a number of you have had questions about these. Touch on fertility because it's something that a number of people are starting to ask about. And then I'm going to present the experience from the two largest clinics. So we have the first multidisciplinary clinic. You see I've been having a Zweibier already in Birmingham. There is also going to be one in London, and there will probably be a smaller one elsewhere. So the first is hormones, puberty, and growth. Now, if you want to know anything, where do you go? Wikipedia. So a hormone is a chemical released by a gland. It passes around the blood, and it works at a different part of the body. So quite often you can measure the hormones in the blood. Some of them you can measure, some of them are more difficult to measure, and we'll talk about those. And this is the endocrine system in the body. And so the ones we're going to talk about today are the pituitary gland, the hypothalamus, and the gonads, which are the ovaries in the girl and the testicles in a boy. I presented this in America, and somebody pointed out that there were male and female organs in the same diagram. And they said, yes, you're absolutely correct, because they have the testicles, and they also have a brain. Needless to say, it was a woman who made that joke, not me. So the first thing to remember, because we've had discussions about this, is that the sex hormones are produced from two different glands, okay? The major puberty hormones are produced from the gonads, so from the testicles and from the ovaries, but in addition, the adrenal glands, which sit above the kidneys, also produce hormones. So sometimes parents say to me, so in a boy, there's no signs of the testicles getting larger, but they have hair over their pubis. Has anyone come across that? You get pubic hair, but you don't get testicular enlargement. That is probably due to adrenal hormones and not puberty hormones. And we think that the adrenals work all right in CHARGE syndrome. And then, of course, there are the gonads. We refer to the gonads are the sex glands, so the ovaries in girls and testicles in boys. So the sex hormones produce a growth spurt. They also, in girls, produce breast development, which in girls is the first signs of puberty, and they also produce development of the genitals in boys. And there's a complex mechanism. I'm not going to go through it in great detail, but the major drive is from an area within the brain called the hypothalamus. It then produces hormones which get the pituitary, which hangs under the brain to secrete hormones. These, in a boy, would produce sperm and male hormones, and a girl will generate eggs and estrogen, and they both all feed back. But of course, the hormones are quite complicated. In a girl, if you're looking at the menstrual cycle, there are two different hormones. There's estrogen for the first half, and there's also progesterone for the second half. So in order to have regular periods, you need to have both estrogen and also progesterone. And this obviously is over 4 weeks. So the hormones gradually rise and then fall off again, and then again rise and fall off again. So most of what we're doing in terms of hormone replacement therapy is replacing what is not being produced in a natural fashion. And this is testosterone. Now remember, that last graph was over 4 weeks. This is over 24 hours. So the testosterone level rises overnight, reaches a peak in the morning, and then falls off during the course of the day. So again, ideally, the replacement therapy we should be doing does this. And the reason that hormones are important is this is just showing the different parts of your growth. So this is a growth curve for a child, okay? And there's actually 3 parts of this. And unfortunately, all of the parts of the growth are affected in CHARGE. So the infancy, this first part, remember, some people have a rule, if you take your child's height on their 2nd birthday and they double it, that's how tall they're going to be. Now, that's probably not entirely true for boys, but for girls, it means that by the time you're 2 years of age, you've actually completed 50% of your growth, okay? And this part is mainly nutrition. So children who don't grow in the first year or so of life, it's usually because, and especially in children with CHARGE, who have gastroesophageal reflux, who may have clefting, who have gastrostomy, it's nearly always that they have inadequate calories. So a child with CHARGE, and we know that children have multiple hospitalizations or spend a lot of time in hospital, often don't have as good nutrition. So if your child in the first few years of life is not growing so well, it's probably for whatever reason that they're not getting enough calories. So the treatment is not hormones, it's usually calories. Throughout childhood, they grow relatively steadily, and we know in children with CHARGE that they grow generally quite well. What usually happens is by that stage they are quite short, and they're usually tracking along the bottom of the normal range. And this is a combination of different hormones. And then right at the top, adding about 20 to 30 centimeters to your height is puberty. So that is, remember what I said about hormones? So they're different hormones produced by different glands. So you have growth hormone, which makes you grow, but also sex hormones, the puberty hormones, and you need both growth hormone and puberty hormones to give yourself the growth spurt. If you don't, you just continue to grow at a steady rate, and you can continue to grow into your 20s and 30s. I'm seeing patients with CHARGE who've not had sex steroid treatment who would continue to grow into their 20s or 30s or even 40s, whereas most children will have completed their growth by the end of their teens. So you might say that sounds like a good idea, but I'll tell you in a minute why it's not such a good idea. Okay, and this just shows everything all together. So it's the different stages of breast development, different stages of their growth. So girls, as soon as they get some breast development, they have a growth spurt. The onset of their periods, what we call menarche, occurs about 2 to 3 years after they start their growth, after they enter puberty. And once your periods start, it's usually telling you that you're coming towards the end of your growing. In normal girls, they grow an average of about 5 to 6 centimeters. Okay? In boys, they're slower. Boys enter puberty about the same time as girls, but their testicles enlarge, and unless you have the special beads, have you seen the special beads when you go to the endocrinologist? They're graduated in different sizes. Now, there are 2 different sizes of beads. The English one goes up to 25 mils. The German ones go up to 30 mils. Now, don't ask me why, but maybe there's something the Germans know that the English people don't know. I have a set of German beads. I'll bring them if you invite me next time. And obviously, you will get enlargement in the testicles normally, growth of the penis, and then the growth spurt is usually quite late on. And things like the voice lowering, so the voice breaking, and the shaving usually occur quite late on. So the voice breaking occurs late in puberty, and shaving often will occur several years after growth is completed. So it's how everything fits in together. So let's just look at a bit at CHARGE. Several of you come with children who you're thinking about treatment, and so a lot of the questions I've asked you are, firstly, can they smell normally? Can they smell cooking smells, perfume? And I know some of you had actually had your children tested. It sounds crazy that if you can't smell normally, that could affect your puberty, but there's a strong association between absent sense of smell and not going through puberty. And there's another condition which is sometimes confused and is thought to have an overlap called Kalman Syndrome. Has anyone heard of Kalman Syndrome? Some of you have been told, no, your child doesn't have CHARGE, they have Kalman Syndrome. Kalman Syndrome, so Kalman Syndrome was named by Fred Kalman, who was of German origin, again, but he was in America. But that's absent sense of smell and not going through puberty. But it's part of the CHARGE syndrome in many parts. So if your child doesn't have a good sense of smell, it's one of the pointers that they may not go through puberty on their own. So you should ask about that. The other thing is that we've talked about puberty hormones, but the same hormones in boys are involved in the testicles coming down. Remember, the testicles start their development around the kidneys, and then they work their way down through your abdomen, and then they come, in the last part of the pregnancy, they come through the groin down. So the overall distance is about 20 or 30 centimeters, quite a long way, and they have to bring all their blood vessels and all their tubes down with them. And that last part where they come from inside your abdomen down into your sac, your scrotum, are under the control of the same hormones that put you into puberty. So if you have a son who's required assistance with having their testicles brought down surgically, and how many of you have had sons who've had to have what's called orchidopexy? Yeah. Or those of you who've got sons, have they had to have testosterone treatment because the penis is small? Okay, so both of those would be an indicator that you may need some assistance with puberty. And what constitutes a micropenis? There are everything. In the same way as I have my magic beads, I have a chart which will tell me. But in America, they have a rule pinch an inch. Okay, 2.5 centimeters, 2 to 2.5 centimeters. If the penis, properly measured, is less than 2 to 2.5 centimeters when a boy is born, it's usually considered to be a micropenis. But as I've said before, pubic hair can arise from different glands. So having pubic hair and no other signs of puberty doesn't necessarily mean your child's going into puberty. So there's a number of reasons why. So we were talking about the hypothalamus, the pituitary, and the gonads. So this is either the ovaries or the testicles. So you can either have where the ovaries or the testicles aren't functioning properly, in which case the hormone levels coming out of the pituitary are high, and you can see that in other syndromes such as Down syndrome and Klinefelter syndrome. Or you can have a failure of production of the hormones in the hypothalamus and the pituitary, in which case the levels of hormones coming out are low. And that has a very long name, which is why I rarely use it, and it's called Hypogonadotropic Hypogonadism. And sometimes when you get a clinic letter, you'll see this very, I know the Germans like to put all the words together, and it's a very, very long word, Hypogonadotropic Hypogonadism, or hypo-HH, or hypo-HH, and that's what it means. It just means that the reason you're not going through puberty is the failure of the system up here to drive things, because that's what usually puts you into puberty. And so there are ways that you can test that. So again, we've got the hypothalamus, the pituitary, and the testicles or the ovaries. You can see whether the pituitary is producing hormones by actually adding in those hormones. Or alternatively, you can stimulate the testicles. You wouldn't do this in girls because you would overstimulate the ovaries by actually giving the equivalent to this, which is called HCG. So this one, plastic needle, usually it takes 1 hour, okay? You get blood samples at 0 and 30 and 60 minutes. This one usually involves a number of injections and measuring the testosterone level before and after. So how many of you have had children who've had those tests done? A few. Those are the best way of doing it, but even those aren't perfect. So the other question is, so we'll go through so the hormones can be quite complex, but there's also, because there's a normal range, if you fall outside the normal range, there's more likely to be a problem. So it's a clinical diagnosis. So the first one is the puberty delayed? So that you go into puberty, but you do that late. That can be a normal phenomenon. So if you think, for instance, of women commencing their periods, the average is 12.5, but some women will start their periods at 10.5, and some entirely normal women will start their periods at 14.5. That's all normal. One would be later, but it would still be normal. What happens, remember you have those stages, and I say it's like when you have your car and you drive up through the gears. You may be fine in gear 1 and gear 2, but when you try and put the accelerator, the car won't go through all the gears because you need more acceleration. So you're driving in 3rd gear instead of 5th gear. So sometimes that can happen because the equivalent of the engine, which is your pituitary gland, will not do that. So you may get part the way in and stop. Or it may just not happen at all. So the normal cutoff, so if a girl is not showing signs of breast development by 13, and a boy is not showing signs of enlargement of the testicles by 14, we would usually call that delayed puberty. And the way you do that is, as I've said, you do staging. So your pediatric endocrinologist would look at their armpits, see if there's any hair at their pubis. For girls, they'd look at their breast development, and boys, they'd examine their genitalia and their testicles. Okay? And there are other tests that you can do. Who's had an X-ray of their wrist, bone age? Did anyone explain to you what a bone age is? Does anyone? Okay. In England, our Queen has just had her official 90th birthday. In fact, her real birthday was in April. She has 2 birthdays. Everyone in this room would have had 2 birthdays. Because one is, if your birthday is on the 10th of May, on that date, it's your birthday, okay? But, as we've already said, if you look at women having periods, some women's body clock will tick over faster, so they'll start their period at 10, so they'll stop growing early. And some women, body clock will tick over slower, so they'll start their periods at 14. So the X-ray looks at the growing ends of the bones, and that's the only reason we do it, because there's lots and lots of growing ends. It will tell you how many more years you've got of growing before you stop growing. So if you are 14 years of age and you have the bone development of a 12-year-old, you then compare your child in terms of their size, not with children of the same age, but children who are 2 years younger. Now, clearly, if they still are very short, comparing them to the 12-year-olds, then there could be an issue there. So it's an assessment of the biological age of your body. And we know that in CHARGE syndrome, generally, even those kids who develop normally tend to have a tick over more slowly and develop more slowly. So that's what the bone age does. So you can have single blood tests, but I've always said that the hormonal system is very complicated. And of course, we're talking about things working in isolation, but of course, all these hormones interact with each other. Some, as we've seen, are produced in pulses through the day. Some are produced in lots of pulses. Some are produced over weeks and weeks. So a single blood test doesn't always give you the information you want. It's probably good for things like thyroid, but it may not help. So what you often end up doing is doing stimulation tests, and even those aren't perfect. So for a girl, I'd probably do an LH-RH test, checking that the pituitary is able to produce the puberty hormones, and in addition, for a boy, I would see whether the testicles are able to produce testosterone. Is everyone happy with that? Is people confused? If you're not confused, you probably don't understand it, because actually it is highly confusing. So don't ask me too many questions afterwards. Okay, so we'll talk about hormone. So there's a big range of normal, but the question then is, should you allow your children to fail, or should you recognize those children who are likely to need assistance and intervene at an early stage? So a couple of things. The first one is just giving testosterone, because remember, the testicles in a boy will produce testosterone, but they will also produce sperm. If you just give testosterone to a boy, you need other hormones to produce sperm. And part of that enlarges the testicles. So if you just give testosterone to put them through puberty, which many of us do, it won't cause the testicles to enlarge. That's normal. But as I've said, the ovaries and the testicles are also responsible for the production of sperm. But in order, if you're not producing it yourself, you probably need to add in not just testosterone or estrogen, you probably need to add in the hormones that the pituitary isn't adding, which are more frequent injections. Now, you might well say, what is the reason for worrying too much about puberty? Because there are concerns. So I've spoken to a lot of people today who have children who have some challenging behavior. Sometimes they have inappropriate sexual behavior. And the worry is, if I add in sex hormones, is that behavior going to get worse? If we've got girls, some of the parents worry, how will the girl cope with menstruation? But remember, menstruation comes at the very, very end of puberty, an average of 2 to 3 years after you start puberty. And boys can also have problems with persistent erections, which can be problematic. However, the reason that we want to treat is not just for the production of puberty, it's to protect you against osteoporosis. Because most of your bone strength is laid down in your teenage and early 20s. And so this is a bone scan, and this is looking at normal bone, and this is looking at bone. So the bone is like a honeycomb, okay? But if you've got less of it, if you fall, it will fracture. And a quarter of your bone mass is laid down in puberty. And every 10% increase in bone mass reduces your fracture risk by 50%. So you don't need an enormous amount of increase to reduce your fracture risk. And conversely, you don't need a big reduction in how much bone strength you've got before you're at risk of fracturing. And so this shows what happens. So you can see that the bone strength goes up in the teenage years into the 20s. And then, unfortunately, almost whatever we do, it starts falling away from the 20s and 30s. You can see it drops quite a lot in women after they go through the menopause. But this line is pretty much, you can't do anything about it. So if you only get your peak mass up to there, you're going to start decreasing at that sort of rate. So instead of having brittle bones, you know, if we have brittle bones when we're 100, I'm not too bothered about that. But if you have brittle bones when you're 30, if you fall over and you break your hip and you need a hip replacement, that hip replacement will last you 15 years. So if you're 100, that's fine. If you're 30, you'll need another hip replacement when you're 45, and each time you put the hip replacement in, it'll get more and more difficult to put it, because remember, you're not putting it into normal bone, you're putting it into abnormal bone. So there's a significant risk if you get osteoporosis in your 30s and 40s that you could ultimately end up, for instance, in a wheelchair bound or with significant reduced. And there isn't very much, you know, we've had discussions with people today where people say, oh, don't worry, stop the treatment, and if they have a fracture, we'll deal with it. There are medicines that are used in osteoporosis, but they will not return the bone strength back to normal. They'll improve it, but they won't return it back to normal. So not doing anything and then waiting for the osteoporosis to occur and then trying to reverse it currently does not work. So let's look at the options. So there are injections. So the standard is a monthly injection given into the muscle, either into the buttock or into the thigh. But there are also 3-month injections. I've spoken to someone today whose son's on a 3-monthly injection. You can have oral, you can have patch, or you can have gel. And I'll just show you. Remember, you want nice, smooth. You don't want boys with lots of testosterone. They get aggressive. If I give anyone, including the ladies, in this room, a large dose of testosterone, they will get aggressive and unpleasant. In the UK, we call it punchy, okay? Because they are quite aggressive. And that happens in normal people if they're given the wrong dose, okay? So this is the standard treatment that we usually use, and this is an injection given every 3 weeks. Remember, we want nice, smooth levels. So you give the injection, the level goes from 200, so even when you've had it, goes from 200 to 1500. So you get a 5 or 6 times increase in the testosterone. It stays like that and it gradually falls down. So at this time, you don't want to be in the same house with them, okay? At this time, they're probably really nice, but you know you're going to have another injection coming up. So it's quite, there is a period of time, but you will get some fluctuations, and somebody very clearly described fluctuations, and this was on the 3-month injection called Nebido. So it's similar, but it's longer acting. And they described that in the first week after the injection, there's a significant change in behavior, and that gradually improves during the course. And that's got to have something to do with testosterone. So what you're going to ask me is, what's the right dose of testosterone that which will protect you against osteoporosis, but will not produce significant behavioral problems? And there isn't one, because it varies from individual to individual. In normal men, the normal testosterone level is 4 times different, so it depends how people respond to it. So I can't tell you exactly. But you don't want the big fluctuations. So we've been talking about people where, talking to people today where people said, I'm going to have to stop the testosterone because it's causing so many problems, and we'll just have to, somebody was actually recommended, stop the testosterone because we'll have to deal with the consequences of that. So what you should do is give as much testosterone as you can. And this is something that I use, and I know talking to Connie, she uses this in Holland. There is a patch, which is just like a plaster. And I'm sure some of you have children who have hyacinth plaster. So you just stick it on. It does produce some skin irritation. So I use the gel. So it's just like a soap dispenser. And if you have problems and you've had a 3-month injection, you've got to wait 3 months. It's a long time to wait. With this, you can just reduce it or stop it, and it's out the system in 24 hours. So for most of my boys, they're now having Tostrand gel. So the adult range is 4 to 6 pumps, but a lot of my boys will start off with 1 pump every other day to make sure they'll tolerate it, and then you go up to 1 pump, and then you go up to 2 pumps and whatever. Sorry. So. You measure the testosterone level, because actually you can tell. You can do it, but blood, but. Sorry, there's one. So the gentleman's asked, how do you know that it's enough? I know what's optimum, but I also know, because I'm going to be checking the puberty, and I'm going to be checking the growth, and I'm going to be checking the behavior. And we've already said there's no absolute ideal for everybody. So I've got some patients who have, if you read it says 5 to 6 pumps, which is 50 to 60 milligrams a day, is the usual adult dose. But I've got young men with charge in their late teens and early 20s who are on 2 pumps a day. They don't have osteoporosis, they don't have behavioral problems, and their testosterone levels are fine. So I wouldn't say to them, oh, no, you haven't read the leaflet, you must have 5 pumps. You give them as much as they need or they want. But you can always go up, but the important thing is you can always come down. So if there's a behavioral problem, as you go up, you can then either stop or reduce, and then you can back off, and then you can go back up again. So I think most of us are now starting to use it. I think Nebido is good. I don't know whether or not you can give a reduced dose of Nebido, because it may, but you can see you will get some fluctuation. This doesn't produce the same level of fluctuation. And I think it's the variation in those hormones that you don't want to have. So the hormone replacement in girls is, again, there's a little bit of debate, because There are natural hormones. So the natural hormones are commonly used in what we call hormone replacement therapy for women who've been through the menopause. Or there's synthetic estrogens, and they are usually the sort of hormones that are used for women who are on the oral contraceptive pill. They're not that dissimilar. Are you going to go for a tablet? Are you going to go for a patch? We are starting to move towards patches. You can cut the patches into a half, you can cut the patches into a quarter, you can cut them into smaller amounts. So you can start with a small amount and go up. So I think in the next few years, we'll probably move towards that. And then, remember, so this is just of estrogen, but remember you also want estrogen and progesterone to get the period. Now, you don't have to have a period every month. You only need probably, well, it used to be that you needed to have a period every 3 months. Some people now say every 6 months, and some people are saying you probably don't need to have a period. You don't need to have menstruation as long as you have your hormones. So actually you can either reduce the amount of them, and obviously when you're on something like the oral contraceptive pill, they're very light generally. So actually having the periods themselves, and of course you will be able to tell when you're having the period, because the period, if you remember when you're on the oral contraceptive pill, it's when you stop the medication. So you say, okay, this weekend, we've got a quiet weekend, we're not going anywhere, we'll have a period now, and then you stop it and you can prepare for that. But they don't have to be very often. So I think there may be a move towards the patches, and we both, Connie and I, because I've just checked, tend to use the oral contraceptive pill because it's widely available, but actually my adult colleagues often use patches and HRT. I don't think there's a big degree of difference. I have to say the HRT in girls, and in terms of the behavioural problems, I see less behavioural problems in girls on estrogen than I see in boys. But most boys I don't see problems with. So the question is when to start. So we've already said that the normal range is up to 13 in a girl and up to 14 in a boy, and some people would say also girls should have started their first period by 15. So do you wait until that child has failed, so has fallen out the normal range, before introducing it, or if you have a strong suspicion that it's going to be a problem, should you intervene earlier to keep them with their peers? The other thing is, if you start late, you probably need to go up much quicker. If you start early, you can start very slowly and just gradually build up. So my personal feeling, and it's very much after discussion with the parents and the emotional maturity of the child and what we're looking for, is to start earlier, i.e. within the normal range, and build up over a number of years. So my personal practice is usually to start investigating these children at about 10 or 11 years of age to confirm whether or not they're likely to go into puberty on their own. If there is some evidence, I'm happy to observe them. If there isn't, and there's strong indicators that they're going to need some assistance, after discussion with the family, and obviously where appropriate the child, we would probably start sooner rather than later. Now, we've already said what we're doing is we're now starting to have discussions about fertility. There are patients who are we're having discussions with many parents about fertility, and we're also having discussions with people with charge about fertility. We know, now we have CHD7 testing, that there are parents who are CHD7 positive who are clearly fertile, but we are now seeing the cohort that we saw as babies coming through who are also wanting to talk about fertility. So if you've got this, so if the pituitary drive is gone, just adding the sex hormones will not be enough to achieve fertility. You need to be looking at fertility treatment. And you would need to add in the standard gonadotropins. But we've got patients who are going through this, and they're usually given as injections. And there's also some discussions, so at least a couple of you have emailed me, because the question is, does giving some of these pituitary hormones earlier improve the chances of fertility later on? So is pre-treatment. So there's a possible study that people have flagged up from Japan, but it didn't come up with much evidence. But I know, for instance, that Connie is treating with gonadotropins, whereas because historically, there's no evidence that it's certainly in boys that giving testosterone affects the subsequent fertility treatment. I'm not. So it's worthwhile, you know, if people want to start having those discussions, it's worthwhile talking about. So in the last few minutes, I'm going to talk about the UK experience. So as I said, there's 2 large clinics. There's one in London at Great Ormond Street, and there's one in Birmingham. We currently have about 60 patients, so we have our first national clinic in the UK based. But we've got data on about 21 patients. So interesting, about half, remember this is historical data, so about half of them presented at childhood, but at birth, but we still had patients later diagnosis. I saw a patient last year who wasn't diagnosed with CHARGE syndrome until they were 31. So there was still late diagnosis, and they tend to have the slightly more atypical features. And I saw a patient only last week where the parents had been on the web and they said, I think my child might have CHARGE syndrome, and the geneticist said they have got absolutely everything except CHARGE syndrome, and I will do a CHD7 to shut you up. And guess what? CHD7 was positive. She's got CHARGE syndrome. And you know from looking around here that there's no such thing as a typical child with CHARGE. So if in doubt, test. I'm delighted to say that our geneticists are much better. Many of the national and international clinics are either run by a geneticist or a pediatric endocrinologist. And obviously both of, I'd like to think that's because we're the 2 most important people with CHARGE, but I don't think it is. It just happens to be that we're heavily involved with that. But I think the geneticists are getting better. They're not perfect at actually picking up CHD7. So I'm seeing much more younger patients, and I think that's, is that your experience in Germany, that patients are being diagnosed hopefully shortly after birth? So 80% of the boys who had micropenis or undescended testicles, remember they're the same hormone, so it's not surprising, needed help with puberty. We do have boys who go through puberty spontaneously. The only boy who went through puberty on his own, he didn't have micropenis, and one of his testicles was descended. We got referrals through everybody. We are a specialist children's hospital, so we got them through general pediatrics, from the family practitioner, through the surgical specialties, the medical specialties, cardiology, actually small numbers of patients through genetics. The geneticists were often asked for confirmatory diagnosis, but again, we now have a rule in my hospital that if anyone has a coloboma or choanal atresia, that the endocrinologist is asked to review them as a matter of some urgency. So I get all of those patients referred to me. And because coloboma is, there are other causes of coloboma and there are other causes of choanal atresia. But those are the ones generally in the neonatal period, they're the ones that are going to give you a high pickup rate. I'm sure Connie would probably confirm that. And again, we see, so we don't get many through genetics, we get some through neonatal intensive care and some through intensive care. But neither of these 2 hospitals actually have neonatal intensive care. They don't have deliveries there. So the average age of referral was 4 years. But some were referred at 7 years, some were referred at birth. But this was to the endocrine clinic, so I still have patients in my own hospital with CHARGE syndrome who I've still not seen. They contact the family support group, and the family support group say, and what did Jeremy say? And they go, who's Jeremy? So then the family support group has to contact me and say, do you know there's a new baby with CHARGE in the children's hospital? So communication is not perfect. Our main reasons were short stature, micropenis, and so 3/4 of the boys had micropenis. And remember, if you have micropenis and undescended testicles, 80% of the boys needed assistance with puberty, so it's a high indicator. Delayed puberty, and then we also had some just under routine follow-up. We usually recommend routine, unless there's absolutely no other problems, I would usually recommend regular follow-up by a pediatric endocrinologist. So the average height, the median, was at the bottom end of the normal range. Some kids were very, very short. But as you've already seen from here, there are a number of kids with, I've had my photograph taken with one of our boys with CHARGE, and I'm 183 centimeters and he's taller than I am. So who said retarded growth is part of the condition? It's not always. It's not always. And 42% of the children had short stature. I think other than puberty problems, I think hormonal, I may be doing myself out of any more trips to Germany, to the support group. I think apart from problems with puberty, I think although growth is an issue, I don't think most patients with CHARGE syndrome are growth hormone deficient. Do any of you have children on growth hormone? No. Okay. In addition, okay. Oh, lots. Okay. Sometimes they're put on because they're very short, but our experience is it's not very common. So the poor growth in CHARGE is probably part of CHARGE as well. Some of the children, but it's not by any, so I get some people who say, oh, every child with CHARGE syndrome has growth hormone deficiency. They don't. We also know, because Connie's just done a big study, and we've also looked at a lot of our patients, that deficiency of stress hormone, of cortisol, is very, very uncommon. Because if your child is having multiple operations, you don't want them to be stress hormone deficient. They would have to be treated. But actually, the evidence suggests that these children, they have other anesthetic problems, but actually, in terms of their stress hormones, they deal very well with it. There is a recent paper on growth hormone. In fact, ironically, I've tried to get it published for 10 years, and then one of my friends got exactly the same data published last year on growth hormone. It's very limited data because it's retrospective. There's some evidence it may have some benefit in the short term, but there is no long-term data. So this is looking at some of our puberty hormones. So remember, this is seeing what the hormones are like coming out of the pituitary gland. And usually you expect to have a nice rise, okay? You can see that most of these are pretty flat. And actually what's interesting, we've now done 30 or 40. What's interesting is the ones that show a response, so the ones who aren't, I'll try to say it again without Zweibär, hypogonadotropic hypogonadism, which means they have a better response, they're nearly all girls. So the girls have a better response. So in terms of their pituitary hormones, they're less likely to have hypogonadotropic hypogonadism, and as a result, they're more likely to go through puberty on their own. The boys generally have hypogonadotropic hypogonadism. And if you stimulate their testicles with HCG, which is one of the pituitary hormones, they have low rises. I've now done, again, about 10 of these. The sort of levels you'd be expecting to get are 6, 7, 8. You can see many of these boys have very little. And that's really because their testicles are sitting there and they're not being stimulated by the pituitary gland. So the question is, if you want to get the testicles to work on their own, you probably have to give quite a lot of injections of HCG. But some people feel that that is, because this is the hormone that's missing and not that hormone, the natural and appropriate way to do it would be actually to give these hormones, which are HCG and HMG. And some units are doing it, but as I said, it's usually 2 or 3 injections a week, whereas testosterone, remember, is once a month or gel. So I think we'll start to be doing some trials about it. We've got about 30 kids who are pubertal. Only 20% of them went into spontaneous puberty, and only one of those was a boy. I've already talked about the boy. He didn't have a micropenis, and he had one testicle that was descended. So all the boys, if you've got so in our experience, all the boys with micropenis and undescended testicles didn't go into puberty. So the boys were just over half the girls needed some assistance, but over 90% of the boys needed assistance. But that may reflect the fact that, remember, this is not from our CHARGE clinic, this is from our pediatric endocrinology clinic. So we're probably more likely to see children who are having problems. So the figures look quite bad, but as Julie was saying, I'm a glass half full guy, not a glass half empty. So there may well be other kids who are going through puberty, but generally the boys are more likely to need assistance than girls, but some of them will go through. And clearly, if the girls, the other thing to say is if they're going through puberty spontaneously, especially if a girl's having regular periods, they are also potentially fertile. So we've been talking about fertility, but there is also the potential in some of these girls that they can also fall spontaneously pregnant. So don't assume that they may not need contraception. But that's another talk, and I'm not even going to start to talk about that. Okay. So for the girls, we use synthetic estrogen, and we then went up on the dose, and so we put our kids in about 13 years. I think I'm tending to 13 is about the sort of age I'm doing. Some of them obviously presented quite late, and some of them got part of the way through puberty. But the ones who we treated late were generally because they presented late to us, so that we may not have seen them until the time of puberty. So my personal preference, but I know it's only a personal preference, is where it's appropriate, I think you should start early and slowly, because you're less likely to run into problems. So in the girls, we use synthetic estrogen. So something like, so remember the oral contraceptive pill contains 20 to 30 micrograms of ethinyl estradiol. So we start the girls off on 2 micrograms. So it's 1/10 the dose of estrogen in the pill. So you do something like 2, some people do 2, 4, 6, 8, 10, 15 pill. I tend to do 2, 5, 10. So again, you would put them through over 2 to 3 years. So the 2 micrograms will only probably give a small amount of breast development. And because it's estrogen, you may not get, some of the girls also don't have much pubic hair development. So in the boys, traditionally the boys have received intramuscular testosterone. 5 boys did not want it, so we've given them oral capsules. It's not as effective. The absorption is not so good. I have put a number of boys through puberty with topical testosterone gel, and we have changed boys from intramuscular to topical testosterone because their behavior was bad, especially immediately after the testosterone injection. And we've got a small amount of data on adults. I've just started doing an adult clinic with my adult endocrinologist, so we're seeing patients from 16 years onwards. This is from the clinic in London. They had 8 subjects. Some had growth hormone. So they compared their bone. Remember, the problem with bone density is if you're small, your bone density is small. because what you're measuring, if your spine is that big, and remember it's three-dimensional, it'll look more than if it's that big. So you have to make correction, and sometimes when they do what's called a DEXA scan, the bone density scan, they don't correct for height, and that causes problems because that will artificially make them look poor. So we did correcting, and we looked at other groups of patients with hypogonadism. Okay? So these are the other similar patients, or Kalman patients. So you can see they're all quite old. The charge patients tend to be shorter. They tended to be a bit thinner. And so the numbers that you start to worry about is 1 is what we call osteopenia, so it's a bit reduced, and -2 is osteoporosis. So you can see that the spine score was low in these patients, but the rest of it wasn't too bad. So in these patients, but remember this is done retrospectively, these were often late treated, our group of adults with CHARGE syndrome had significant evidence on X-ray of osteoporosis. In addition, we've now got some more data. There is some evidence, it's worthwhile making sure that their parathyroid hormone, because remember there's this crossover with DeGeorge, that their calcium levels are checked, that their parathyroid is checked, and their vitamin D is checked. And quite a lot of my patients are vitamin D deficient, so I think a reasonably good calcium intake, and if they're vitamin D deficient, vitamin D supplementation will also help. But if you have osteoporosis, you cannot completely reverse it with calcium or vitamin or nutritional supplements. They only add together. So that's a quick run through. I'm delighted to say I've got you well before your buffet. I haven't shown any rude photographs, I was promised. Now, I did have to say, we were talking about the Lord of the Rings yesterday, and Nancy at the front announced that she's actually got a Lord of the Rings tattoo. So if you want to ask her to show, it's not in a rude place, you'll be pleased to know. So if you want to ask, so it's in, Nancy's going to come and show you her Lord of the Rings. Thank you very much. Now, actually, she's put the wrong thing on, because actually, do you remember I told you about the Kingdom of Mercia? Hers is Elvish, okay? Lord of the Rings. What she should have done is Rohan, because the Rohan were based on the warriors of the Kingdom of Mercia. And the runes are from northern Germany and Scandinavia. So she would have been much happy. So next time, if she's invited, we'll make sure she has a runish, Mercian Rohan on the other ankle. And thank you very much. Dankeschön. Okay, ja.
Gibt es Fragen? Ja, es gibt Fragen. Wir müssen immer ins Mikro sprechen, sonst kann der Jeremy nicht übersetzt werden. Deutsch, ja.
I can.
Du kannst auch Englisch sprechen.
Okay. Ah ja, okay. Ich mache lieber Deutsch, aber Englisch wäre possible. But I do. Also, ich habe eine Frage, und zwar, Lavinia hat jetzt die Mikropille, also Kombination aus 20 Mikrogramm Östrogen plus Progesteron. Und alle halbe Jahr gibt es einen Blutcheck, wirklich nicht regelmäßig eigentlich. Und beim letzten Mal waren die Leberwerte leicht erhöht, was wir bis jetzt noch nie hatten unter Östrogen, pur Östrogen. Sie bekommen das jetzt seit einem Dreivierteljahr. Wie lange oder wie hoch können wir abwarten? Und was wäre dann die Alternative, wenn es zu hoch geht?
Okay, so we know that the synthetic estrogen is broken down by the liver whereas the natural, what's called a first pass effect, whereas the natural estrogen doesn't tend to be broken down so much, which is one of the theoretical reasons for using natural estrogen rather than synthetic. So so women and girls who are on the oral contraceptive pill, you can see mild abnormalities in the liver function. Often they do not deteriorate. And obviously, many women are on the oral contraceptive pill without problems. But if the levels are abnormal, then one of the options would be to look at a natural estrogen, either by mouth or ideally, again, because it involves passage through the liver, actually as a patch.
Okay, und dann aber die Kombination Östrogen, Progesteron weiter, nur getrennt?
When you the natural estrogen you can also give with progesterone, and some of the patches also have progesterone in them. So it's worthwhile looking at the alternative. You know, very mild abnormalities in liver function tests are not uncommon, but clearly if they were bad abnormalities or they were deteriorating, you might want to look at another alternative. But many of my girls with CHARGE and others similar are very happy on the low-dose pill, and they don't get, so when they take it, they don't have bleeding.
Das ist
Otherwise,
nicht
so no breakthrough bleeding.
It's she has no problems with bleeding and everything. That it's only that I'm a little bit concerned about the rising of the liver.
Yeah. It depends
levels.
how abnormal they are.
Yeah, it's slight.
Okay.
It's not bad yet,
Okay.
but
I would, my personal feeling would be to keep an eye, but there are other alternatives.
okay.
Ja, erstmal vielen Dank für den verständlichen Vortrag, hat mir gut gefallen. Dafür danke. Mein Sohn, der erhält demnächst eine Hormonersatztherapie, dabei soll ihm dann auch dieses HCG gegeben werden. Und da mal meine Frage, ist da mit Nebenwirkungen eigentlich irgendwie zu rechnen, mit vermehrter Möglichkeit der Tumorbildung, oder ist da irgendwas belegt, gibt es da Hinweise darauf, dass es irgendwelche Nebenwirkungen gibt?
HCG has been used for 50 or 60 years, so we have a very good safety profile. The only way to obtain HCG in the past was from urine, and so there was a nunnery where nuns lived in Italy, and they used to urinate into a bucket, and we used to get the HCG from there. You'll be pleased to know we don't do that any longer. It's synthetic. So the HCG is really only replacing so it's a replacement therapy. So it's replacing the hormone that you are not producing yourself. So you would not necessarily anticipate problems, certainly not in boys. So HCG, which is the equivalent of LH, or what we call luteinizing hormone, stimulates the testicles to produce their own testosterone. So that would be the most normal, what we call physiological way of doing it, because it's actually replacing what's being missed. The problem is that the HCG injections have to be given for a while. So how often are you planning to give the injections? Is it several times a week?
Genau, so wie Sie es vorhin auch geschildert hatten, am Anfang mehrmals die Woche, dreimal die Woche, und nachher soll es dann auslaufen und über 1-2 Jahre und dann mit Testosteron weitergeführt werden.
Yeah. So that's probably the optimal way in boys, if their testicles are descended and they look like they're functioning normal, to get the best outcome. But it is quite intensive. If you were looking at fertility in a boy, you would also need to add an HMG. So when they used to have the buckets in the nunnery, the nuns who hadn't had their menopause, weed in one bucket, and that was HCG. And the nuns who'd had their menopause, weed in the other one, and that was called HMG. It's now synthetic as well, you'll be pleased to know. But that is what we call FSH. It's got high levels of FSH. So you need to have testosterone, but you also need to have follicle-stimulating hormone to get the testicles to generate sperm. Because remember, girls are born with 100,000 eggs. Girls do not generate eggs, they're born with them. Boys actually produce sperm. It takes about 3 weeks to produce the sperm. So it's a very different process in terms of the production of it. So with the girls, you're stimulating what they already have. In the boys, you're stimulating them to produce. So that it's a slightly different process, or actually the hormones are similar.
Ich habe noch eine Frage zu den Kindern, die Wachstumshormone bereits nehmen. Führt man die Therapie dann weiter, wenn die Kinder Sexualhormone brauchen, oder hört man mit der Wachstumshormontherapie auf, sobald die Sexualhormontherapie beginnt?
Yeah, if you look at that growth chart that I showed, you produce growth hormone throughout childhood. In fact, you produce growth hormone throughout your life. So it has other effects other than growth hormone. So the growth hormone, which is a daily injection, and the sex hormones, which are monthly injection, so they're different hormones, they combine, so you get one effect of the growth hormone, you get one effect of the sex hormones, and actually the combined effect is greater than each one of them. So you get an additive effect, what we call a synergistic effect. So in order to have a good puberty growth spurt, if you're on growth hormone, you would continue the growth hormone and add in the sex hormones. So you have both of them, because that's what normally happens. So if we don't, we have limited experience in CHARGE and other conditions. So when you want to know what the best way to do things is, you see what nature does, and then you replicate it on the basis that after 4.5 million years, we've probably got it right in terms of working out our hormones. I can't sort it out in 10, 20 years.
Ja, hallo, ich habe noch eine Frage zu meiner Tochter, die ist knapp 18. Sie hat Schambehaarung, sie hat super wenig Brustentwicklung, ich glaube Tenne 1, und hat ihre Menarche auch noch nicht gehabt, wobei späte Menarche bei uns in der Familie liegt. Kann man, also mit 18, meine Mutter und ich auch, kann man da noch ein bisschen zuwarten oder sollte man direkt anfangen mit der Hormonersatztherapie?
So often, if you're looking at height, and if you're looking at development, you also need to include what's happening in the rest of the family. But even though there is late development, if your daughter is showing no signs of breast development, then her periods are even if she developed breast development tomorrow, she's probably not going to start her periods till she's 20. And you may well argue, even with a family history like yours, if she's showing no signs of breast development by 18, I would, at the very least, check the hormone levels out, maybe do an ultrasound, because a pelvic ultrasound is very good to see whether the ovaries are starting to enlarge or whether the womb is starting to enlarge. My feeling would be, is even though there's a strong family history of late development, I would probably want to intervene. Because you can always take them through puberty and then stop afterwards. You know, for many of the children with CHARGE, I suspect that the hormone replacement therapy will be lifelong, but if you're not sure, you can always take them through, part the way through puberty, full the way through puberty, and then stop and then reassess. So I've got patients who are like that.
Ja, ich habe auch noch eine Frage, und zwar unser Sohn
I
ist
have a question too. Our son is 2 years and 10 months old, and he was born with a micro penis and micro testicles. And we did not give him any hormones to have the testes descend, because he also has a tube and his nose was always closed up. It would have been difficult. And my question is, he's under the 2nd percentile in terms of growth. At which point in time should we react and also give growth hormones?
Okay. So are his testicles descended now?
Ja, sie sind runtergeholt worden.
Yes, they were brought down. One consists of residual tissue and the other one is mini tiny.
So So let's take the difference, because people always think hormones are hormones are hormone, but there's lots of, so we've already talked about growth hormone and sex hormone. So you have a little mini, I haven't talked about childhood, we just talked about, but you have a little mini puberty when you're born. So if your son has, in an ideal world, and of course many of these children have lots of other additional problems, so the testicles aren't usually brought down till later, and they're not given testosterone treatment because, again, there's worry that testosterone may affect heart function and cause fluid retention. So quite often you don't, but in an ideal world, if the testicles aren't descended, you'd like to bring them down the first 2 years of life. The earlier the better. And if they're having an anesthetic, do it at the same time to avoid an extra anesthetic. Give them the testosterone early. But as I've already said, the major cause of poor growth in the first year of life in charge babies is just inadequate nutrition. So at 2 years of age, growth hormone doesn't play a huge part in your growing. I'm not saying it doesn't play any part, but in the kids I see with charge who aren't growing well and are short, it's nearly always because they need more calories. So that's when I get, so in my clinic we have a dietitian and speech and language therapy to ensure that they get optimum nutrition. So I'd want to optimize, because the other thing is, if you're not getting enough calories and you give them growth hormone, they won't be able to grow anyway because you have to have calories to grow. So the first thing to do is optimize nutrition. If that still doesn't improve things, I think that charge itself has some restriction on growth. As you know, we're trying to produce some charge syndrome specific growth charts, but certainly from the work I did with Kim Blake, who I know has spoken here before, you know, they tend to drop off in the first year of life and then they parallel along the bottom end, and then they have a poor growth spurt, so they end up relatively short. But as you've seen, there's quite a big variation. So in a relatively young child, for the first 2 to 3 years of life, make sure that nutrition is as good as it can be. And if that means a gastrostomy or a nasogastric tube or a nasojejunal tube, fine.
Ja, hallo. Wenn man Testosteron
Hello. If you take testosterone pills, 40 milligrams mornings and evenings, is it better to take 80 in the morning instead to have a better curve, or is it fine to do it like that?
So we're talking about testosterone capsules, and I think certainly in the UK they're called Restandol, and so they're like an oily capsule. So the adult dose is usually 3 capsules a day. I tend, because the testosterone level is higher in the morning, I tend to give 2 capsules in the morning, but some people like to give it in the morning and in the evening. I think you find a dose that suits you. The absorption is quite variable, which is one of the reasons if the alternative is they don't have any testosterone, then as you've seen, we've had patients we do treat with oral testosterone, but I think probably of the injection and the gel and the capsule, it's my least favorite one. But if you're not going to get them to take anything else, I would always go with that. And there is some data that shows that actually even with the oral testosterone, they do reasonably well. So I would tend to give 2 capsules in the morning, but but I think if you look in the pharmacy, it usually says spread it out through the day. But actually, if you look at the normal production of testosterone, it would tell you probably ought to give it in the morning, because that's the way it normally does.
Ja, und wenn man dann auf das Gel,
And then if you were to switch to the gel to have the same dose, would it be 2 pumps in the morning, or? Because the endocrinologist said it would be difficult with the gel to really assess the quantity.
So the adult dose of the capsules is 3 a day, and the adult dose of the gel is 6 pumps. So I work on I'm a very simple person. I work on the basis 2 pumps equals 1 capsule. So you could do 2 pumps in the day. The problem is if you see the gel, it produces stable levels. The Restandol will produce that. But, you know, I don't see major behavioral problems on my patients on Restandol because, again, if you have a problem, you just back off. But I work on the basis of 1 capsule equals 2 pumps. So if you did want to change, I would switch from 40 milligrams of testosterone to start off with 1 pump, see how you go, leave that for a week or so, and then build up to 2 pumps after that. But I'd work about 2 pumps being about right.
Also 2 Pumpstöße für 80.
So 2 pumps, two pumps for 80 milligrams.
2 Pumpstöße für 80.
So you have, sorry, yeah, so you're on 80 milligrams a day. Yeah, so that would be, so that would be 4 pumps, 3 to 4 pumps. Sorry, I'd forgotten he was on twice daily.
Das ist jetzt eine allgemeine Frage, nur
This is
weil
a general question, just because I know that it's one that is asked very frequently. For how long is it possible to start with this hormone therapy? I mean, if parents have waited for a very long time, we're not talking 18 years of age, but say 25, maybe 30 years of age, and nothing has happened so far. They haven't had any hormone therapy, but the children never made it into puberty.
I think my attitude is it's never too late. Okay? In the same way as if you're having behavioral problems with sex hormones, a small amount is better than nothing. Okay. So if you give 1 capsule every other day or 1 pump every other day or very small doses, I think it's better than nothing. Remember, I still see quite a lot of young adults with CHARGE who've not had sex hormone replacement. My colleagues would always take the view. In fact, I saw somebody with Kalman Syndrome, who was somebody's uncle. We started him on sex hormone replacement therapy, and he was 54. So it's never too late. You know, ideally, nature tells us what is the right way to do it, and we generally follow that. But if you're outside of what nature does, then you would always say, well, it's better to do. So if somebody's in their 20s and they've not had hormone replacement therapy for whatever, I would still recommend, but I would take it slowly. I'd take it slowly, because if you've not been, so the man who was 54, when we went to visit, he was somebody's uncle because this is inherited. He had fallen over the week before and he'd broken his arm. He'd fractured his humerus. And when you looked at his x-ray, it looked like that osteoporotic one. There was no bone there at all. We gave him the smallest dose of testosterone. It was about 1/4 of the recommended starting dose for a child. And he came back and I said, did it work? He said, I had an erection for 2 days. Now, that's actually not a good thing to have, because you need to go to hospital if you have. So it was not a good thing, but that was because he'd never, ever seen any testosterone, so you have to start really, really slowly.
Okay. Yeah. And someone else asking? Okay.
Ja, hallo, ich habe eine Frage. Unser Sohn
Hello,
ist
I have a
21.
question. Our son is 21 years old. Since he was 15, he has been given testosterone. He gets Nibido every 10 weeks by injection. Now, I'd like to know about the HCG that you've described. I've never heard about this. I'm a bit shocked. Don't know what that is. Can something still be done? Because his testicles are still very small and he's quite unhappy. Is it possible at that age to do something?
The answer is yes. Okay, so as I've said, you know, HCG comes in and out of popularity. So if you are seeking fertility, then you would need to have HCG and probably HMG. The question, but if you want sexual characteristics, testosterone is fine. So there's been lots of debates. The first debate is, if you give testosterone to put somebody through puberty, does it affect later on their potential for fertility, because we have other patients with conditions like Kalman Syndrome, where people say the fertility is up to 70% in males. So the evidence suggests that giving testosterone to produce what we call secondary sexual characteristics and prevent osteoporosis is fine. Most people still do that. The question is pre-treating beneficial because it will increase the size of the testicles? But we've already heard that if you want to go with HCG, it's a much more intensive program. And so I've moved away from giving HCG. In fact, one of my first ever papers that I wrote 25 years ago was on looking at HCG therapy. Sometimes the treatment needs to go on for months or even years. So, and it can be 2 or 3 injections a week. So it's quite intensive. So the feeling is the current feeling is if you want to go through puberty, then testosterone is fine. If you want to be looking at fertility, then you need HCG and HMG. The question is if you're wanting to look in the future, does pre-treating with HCG before you start the testosterone improve things? I think there is very little data. So some people will feel that HCG 3 injections a week is fine. It'll produce the same level of testosterone probably as having a gel or a capsule. It may improve your chances of fertility, but there's actually not very much data. So it's always a balance. It's always getting that balance. And I think with so little data, even looking at other groups, I take a very pragmatic approach. And I think it's a very, very much an approach that you have to take based on discussion with the family, the needs of the family, the needs of the child or the adolescent or the young adult. If you're looking just for sex hormone replacement therapy to protect against osteoporosis and not have behavioral problems, it's very different from somebody who's going to be looking long-term for a family. So I think you need to almost work out at an early stage what outcomes you're looking for, because otherwise you can be giving a lot of unnecessary or inappropriate therapy. Does that answer your question, or does it just make it even more confusing? We're going to need to do multi-center, multinational studies to answer these questions, and it will probably take 10 or 20 years to get some of these answers. Because, as I said, what I do pragmatically in my clinic and we do in London is slightly different from what Connie does, and I suspect what other people. I've been hearing today from different people who, some doctors are saying, no, don't do anything until they've fallen out the normal range, and some of them are saying, we'll keep them in the normal range. It's hugely variable. I don't think anything's been shown to be much, much better than everything else. Okay?
Okay.
Okay, there's a question.
Hello, thank you, Dr. Kirk, for talking to us about this today. I had a question, and if this is too far out of the scope, just let me know. But I was curious, in your experience, how do you talk to children, adolescents, young adults about these kind of concepts and ideas about puberty and fertility? Is there something that's been helpful to do that, or a way that you go about doing that with families?
I think with any child, it needs to be age and child appropriate. I've actually, as it happens, I've co-written a sex education manual for boys and for girls. I don't receive any money for it, so if you want to go out and buy it, it's called What's Happening to It. And it just explains normal puberty. But it needs to be, parents of those of us who've got children, when do you talk to them about it? What do you tell them? Do you wait for them to come and ask you? In the United Kingdom, you get the discussion in the normal school when you're about 9 or 10 years of age. If you have a child with CHARGE, the information has to be provided in an entirely individualized way. So, the conversations I've had with parents and with children and young adults at the consultations have varied enormously from, we just want a dose of, we recognize that you have to give sex hormones, but it's producing major behavioral problems. And so what is the minimum dose we can do to protect against osteoporosis? and not produce inappropriate sexual behavior, which is entirely appropriate for that person compared to, you know, I'm at a normal school, I'm starting to show interest in boys, girls, you know, I want to be asking about my long-term fertility. So huge, I think it has to be individualized. And you know, one of the great benefits of running a clinic is I have a psychologist in that clinic who also runs other clinics for children with disorders involving puberty. So she's very good at that. But and it also enables you to build up a relationship with these families. So the parent, you need to discuss, you know, it needs to be a holistic care to make sure that what you're providing is absolutely appropriate for that child.
Thank you.
I think the only hormone problem they have is that their blood sugars have dropped so low because they're waiting for the buffet that we must let them go and have some food.
Ja, vielen Dank.
Dankeschön. Thanks so much.
Oh, still have time.
No. People need a bit of that.
Vielen Dank, Jeremy. 18
Thank you so much, Jeremy. At 6 p.m., we're going to start our buffet back there, like always, and also downstairs. And also we have tables and chairs outside. So thank you.
It's been a great